Hey there, fellow PAs. Ready for another deep dive? We're tackling a topic, like the back of your hand respiratory conditions.
Always a hot topic.
You got that right.
Yeah.
We're talking everything from that cough that just won't quit to more, let's say, intriguing cases. Pneumoconiosis. Anyone.
Oh, yeah, we're going there. Get ready to brush up on your respiratory knowledge.
Exactly. Expert speaker, ready to decode these medical mysteries and arm ourselves with the latest and greatest.
Let's do it. You might be surprised what a difference a few key insights can make in your practice.
All right, let's jump right in with atelectasis. Now, we all know it's a collapsed lung, but you'd think you'd pull everything in the chest towards it, right?
Right, you'd think so. But here's where it gets interesting. A mediastinal shift, that space between the lungs, it can actually give us clues.
Oh, I see where you're going with this.
Exactly. If that mediastinum shifts towards the collapse, it often means we're looking at an obstruction. Something's blocking the airway. But get this, if it shifts away, it could be fluid buildup or even air leaking into that chest cavity, like a pneumothorax.
It's like a clue to help us solve the case.
Right.
Speaking of intense, let's talk about those patients struggling to breathe acute respiratory distress. I remember this one case back in PA school. A patient came in after inhaling fumes.
Oh, no.
And within hours, he was fighting for every breath. It was a stark reminder of how quickly things can spiral with ARDS.
ARDS is definitely a rapid onset situation. It's like the alveoli, those tiny air sacs, are drowning, making it impossible for the blood to get oxygen. Sepsis, trauma, severe pneumonia, they can all be triggers.
And then there's that classic point of confusion, obstructive versus restrictive lung diseases.
Yeah.
It's all about how those airways are being compromised.
Exactly. Imagine breathing through a straw. That's your obstructive lung disease. Something's blocking airflow, making it hard to exhale. COPD, asthma. Now, picture trying to inflate one of those tiny stiff balloons.
Okay, yeah.
That's restrictive, like pulmonary fibrosis. Lung expansion is limited, making it tough to even inhale.
And these differences aren't just theoretical, right? They show up on those PFTs we're always ordering.
Absolutely. PFTs give us a peek into the mechanics of breathing. Obstructive disease, you'll typically see a low FEV1 FVC ratio. It's comparing how much air someone can blow out in 1 second to their total lung capacity, a low ratio. They're struggling to get air out quickly. That's your obstruction.
That makes sense.
Now, restrictive, it's more about the total lung capacity being reduced. That balloon just can't inflate.
So we've got those distinctions down. Now let's talk about COPD. And there's a myth I want to bust right now. It's not just a smoker's disease.
Right. While smoking is a major risk factor, other things like air pollution and even genetics play a role.
I've had patients who've never touched a cigarette in their life get that diagnosis.
Exactly. Like with alpha-1 antitrypsin deficiency, your body doesn't produce enough of a protein that protects your lungs without it. You're more susceptible to emphysema even if you've never smoked.
See, it's not always so straightforward. Speaking of emphysema, I used to think it was just one condition. Turns out there are 4 main types.
That's right. Each one affects the lungs differently. Centriacinar, the most common one we see in smokers, mainly damages the small airways. Panacinar, though, that's linked to that alpha-1 antitrypsin deficiency we talked about and involves the entire air sac.
Wow, so it's not a one-size-fits-all diagnosis.
Not at all.
Now let's talk about asthma, another chronic condition that can really impact a patient's life.
Definitely. Asthma is all about inflammation, right? And hyperreactive airways.
Ugh, tell me about it.
It's like their immune system is stuck on high alert. Dust mites, pollen, even stress, and boom.
You're preaching to the choir. I've dealt with asthma my whole life. Dust mites are my nemesis. I swear they're out to get me.
Well, it affects everyone differently. Some folks have mild symptoms now and then. Others battle severe, persistent asthma.
Exactly. And that's why knowing those triggers, managing that inflammation, and having those rescue inhalers handy is key.
For sure.
Now, bronchiectasis. It's not one we talk about every day, but it's important to recognize.
Definitely. Think of it this way. Bronchiectasis is what happens when the walls of your bronchi, those airways, become damaged and permanently widened.
Okay, I'm picturing it.
Persistent cough, lots of thick mucus, sometimes even tinged with blood. And because those airways are damaged, bacteria can easily set up camp, leading to more infections.
A vicious cycle.
Exactly.
Early diagnosis and treatment are key here, just like with many respiratory conditions. Okay, let's zoom out to a broader category now. Interstitial lung diseases. These target the delicate tissue between those air sacs, and they can be quite diverse.
They are.
I often describe it to patients as scar tissue building up in the lungs, making them stiff and difficult to inflate. Does that sound right?
That's a great way to put it. And it highlights why these diseases often cause shortness of breath, especially with exertion. One particularly serious type is idiopathic pulmonary fibrosis, or IPF. And the frustrating part is we often don't know the exact cause.
So it's like the lungs are slowly being replaced by scar tissue, making it harder and harder to breathe.
And while we don't have a cure for IPF, early diagnosis is crucial. The sooner we can identify it, the sooner we can start treatments to manage symptoms and slow down that progression.
Absolutely. We've also got pneumoconiosis, right? That group of interstitial lung diseases caused by inhaling things like coal dust, silica, asbestos.
Right. Things we might not even be able to see.
It's scary to think something as seemingly harmless as dust can have such a huge impact on our health.
It's a good reminder that sometimes the greatest dangers are the ones we can't even see.
Very true. Now, we can't talk about respiratory conditions without addressing lung cancer. Sadly, we see our fair share of cases.
And it's not a one-size-fits-all diagnosis. There are those 4 main types: adenocarcinoma, squamous cell carcinoma, large cell carcinoma, and small cell lung cancer, each with its own characteristics and risk factors.
And while smoking is a major risk factor for most lung cancers, we can't forget about those other culprits. Radon, asbestos, air pollution.
Right, like adenocarcinoma. We're seeing that one diagnosed more and more in non-smokers. That's why it's so important to get a good history, consider all potential exposures, and really keep lung cancer on our radar, even in patients who don't fit that typical profile.
Absolutely. And those symptoms can be so varied, too. A persistent cough, coughing up blood, shortness of breath, unexplained weight loss, chest pain.
And they can overlap with so many other conditions.
Exactly, which is why that high index of suspicion is crucial, especially in those patients with a history of smoking or other risk factors. The earlier we can catch it, the better.
I completely agree.
Now, let's talk about a couple of conditions that can cause trouble in the pleural space, that area surrounding the lungs. First up, pleural effusions.
Seems pretty straightforward. Fluid building up around the lungs.
It is, but the causes can be as diverse as our patients. We could be talking infection,
Yeah.
heart failure, cancer.
Wow. Okay. And then there's pneumothorax. Air getting trapped in the chest cavity. Talk about a lung emergency. And it can happen in a few different ways, too. Spontaneous pneumothorax, which often pops up in young, healthy people, especially those tall, thin men. They could be going about their day and suddenly, bam, sharp chest pain, difficulty breathing.
It sounds terrifying.
It can be. Then you've got traumatic pneumothorax, which is usually caused by an injury, like a rib fracture.
Okay, so more of a direct injury.
Right. And then there's tension pneumothorax, the most serious type.
The one where air can get in but can't get out.
Exactly. Creating that one-way valve and putting pressure on the heart and lungs.
That's a true medical emergency. We need to be ready to act fast, relieve that pressure.
Absolutely. Needle decompression, chest tube insertion. We need to be ready for those life-saving interventions.
Now, before we move on to our next source, which dives into infections like pneumonia, I want to touch on a less common but equally important condition: malignant mesothelioma. This one hits close to home for a lot of people, especially those who've worked in certain industries.
You're talking about asbestos exposure.
Exactly. It's a rare and aggressive cancer that affects the lining of the lungs. And unfortunately, it often presents at a late stage, making treatment challenging.
It's definitely one we want to catch early, if we can.
That's why it's so important for anyone with a history of asbestos exposure, even if it was decades ago, to be aware of the symptoms and to seek medical attention if they experience any changes. We're talking persistent cough, chest pain, shortness of breath, unexplained weight loss.
Early detection, while challenging, offers the best chance of a positive outcome. It's a conversation we need to be having with our patients, especially those who might be at risk.
All right, let's switch gears and talk about those infections that keep us busy. You know what I'm talking about. Community-acquired bacterial pneumonia, CABP, we see it all the time.
All the time. But a little refresher never hurts, especially when you consider all the usual suspects we see with this one.
Right, it's like a who's who of bacteria, each with their own calling card.
Streptococcus pneumonia, that's our headliner. But then you've got Haemophilus influenza, Staphylococcus aureus, Legionella. Even Mycoplasma pneumonia can really stir up some trouble.
And those symptoms are often our first clue, right? Fever, cough, chest pain, that feeling of not being able to get enough air.
Definitely. But here's the thing. The presentation can be a bit tricky. It really depends on who the culprit is and the patient's overall health.
So it's not always crystal clear.
Not always. For instance, Haemophilus influenza tends to target older adults, while Mycoplasma pneumonia, that one loves to pop up in younger folks, and it often presents as that atypical pneumonia. You know, those cases that don't quite fit the mold.
Those atypical pneumonias can be tricky. And speaking of curveballs, viral pneumonia, while often milder than bacterial pneumonia, can still really knock someone down.
Oh, absolutely. Cough, fever, fatigue, they might not sound too bad compared to a raging bacterial infection, but those symptoms can linger. And we have to remember, viral pneumonia can pave the way for those opportunistic bacteria we talked about earlier.
Like, they're just waiting for a chance to jump in. So we've got to be on the lookout for those complications, especially in our more vulnerable patients.
Exactly. Now let's switch gears again. Hospital-acquired pneumonia, or HAP. We're in a whole different ball game now.
This is where things get really interesting, right? These patients are already dealing with other health issues, and then, bam, they get hit with an infection on top of it all. And we're talking about some pretty tough customers here.
You said it. Pseudomonas aeruginosa, Staphylococcus aureus, don't forget about MRSA, Klebsiella pneumonia. These guys are in a league of their own.
They're like the superheroes of the bacterial world, resistant to everything. It's like they've evolved in that hospital environment, making them even harder to fight.
It's true, they've adapted. And let's not forget about aspiration pneumonia, a real concern in the hospital setting, especially if a patient has trouble swallowing or isn't fully alert.
All right, those silent aspirators. Patients who've had a stroke, have altered mental status, or even those dealing with GE or D, we want to do everything we can to prevent that food, liquid, or even saliva from ending up in the lungs.
Absolutely. Now, let's talk about a global health concern that's still very relevant today. Tuberculosis.
It's a good reminder that some diseases never really go away, even with all the advances we've made in medicine.
It's true, and TB can be a tricky one. You can actually be infected with Mycobacterium tuberculosis, the bacteria that causes TB, without showing any symptoms.
Whoa, really?
Yep, and that's where that PPD skin test comes in. It's like our secret weapon.
It's like we're playing detective, trying to figure out if someone's had a run-in with TB at some point.
Exactly. A positive test means they've been exposed, but it doesn't necessarily mean they're contagious or will develop active TB.
So it's all about figuring out who's been exposed and who's actually sick. And there's also that distinction between primary and secondary TB, right?
You got it. Primary TB is that initial infection. It often hides out, mimicking those flu-like symptoms we see all the time. But secondary TB, that's a whole different story.
That's the one we really worry about, right?
Exactly. It's a reactivation of an old infection, and it can be a real problem. We might see coughing up blood, sometimes even blood-streaked sputum, night sweats, weight loss. And it often goes for the upper lobes of the lungs, leaving those cavities we see on imaging.
And then there's Mycobacterium avium complex, or MAC. We often see this one in our immunocompromised patients.
Right. MAC is opportunistic. If the immune system is down, it's ready to pounce. And it can be a bit of a chameleon, too, causing all sorts of symptoms. A nagging cough, weight loss, sometimes even more serious stuff like disseminated disease.
Definitely something we need to keep in mind, especially when we're managing patients with conditions like advanced HIV/AIDS. Early diagnosis and treatment are key, just like with so many of these conditions.
You've got that right. It's all about connecting the dots and recognizing those subtle clues that can guide our diagnosis and treatment.
Well said. Now, how about we take a little detour into the world of fungal infections?
Fungal infections, those cases that remind us it's not always just bacteria we're dealing with.
We've got our fair share, too. Histoplasmosis, coccidioidiopicomycosis, blastomycosis, all caused by inhaling fungal spores, but each one has its favorite spots, which is a good reminder to think about where our patients are from or if they've traveled recently.
It's like medical geography.
Right. Histoplasmosis loves those river valleys, the Ohio and Mississippi rivers.
And then there's coccidioidomycosis, or valley fever. That one's all about the dry, dusty southwest Arizona, California.
And blastomycosis is hanging out in the eastern U.S. and parts of Canada.
Yeah.
So many different players in different locations. So if we have a patient with respiratory symptoms and they've been to one of these areas, we know to keep our fungal radar up.
Exactly. It's all about putting those puzzle pieces together. Speaking of puzzles, lung cancer. We've got those four main types: adenocarcinoma, squamous cell carcinoma, large cell carcinoma, and small cell.
And while we've talked about risk factors, smoking being a big one, those symptoms can be so subtle, so easy to miss.
Absolutely. A cough that just won't quit, coughing up blood, shortness of breath, unexplained weight loss. These are things we see all the time in our clinics.
It's like they're hiding in plain sight. We've really got to be on top of our game asking those specific questions, getting that chest x-ray if we need it, trusting our gut when something feels off.
100%. Now, have you ever encountered a pulmonary carcinoid tumor?
I've seen a few cases here and there. They're definitely not as common as some of the other conditions we've talked about.
They're a different beast, slow growing, but they can throw some curveballs our way because they can release hormones.
Oh, right. Carcinoid syndrome, flushing, diarrhea, that racing heart.
Exactly. Imagine this. A patient comes in, maybe with a cough, some wheezing, even coughing up blood. Sounds pretty standard, right? But then you notice they're flushed. They mention having diarrhea, and their heart rate is through the roof.
It's like those seemingly unrelated pieces of information suddenly come together, and you realize it's all connected.
It's what makes pulmonary medicine so fascinating and challenging, too. We're like medical detectives, always on the lookout for those little hints that can lead us to the right diagnosis.
I like that. The medical detectives of the respiratory system. All right, before we move on, let's circle back to those conditions affecting the pleural space. Pleural effusions and pneumothorax. We've gone over the basics, but the source material dives into some more specific types that I think are worth exploring.
Let's do it.
So pleural effusions, it's not just about fluid being there, it's about what kind of fluid is hanging out around the lungs. We've got hydrothorax, hemothorax, and chylothorax.
Right. Each one tells a different story. Hydrothorax, that's our most common type. It's an excess of watery fluid, often caused by things like heart failure or kidney disease.
Like the lungs are waterlogged.
Exactly. And then you've got hemothorax, and that's a whole different situation. We're talking about blood in the pleural space now.
Definitely a red flag.
Absolutely. Hemothorax usually points to some kind of injury. A rib fracture, a penetrating wound, something that's caused bleeding.
Okay, and then there's chylothorax. That one always throws me for a loop.
It's definitely less common. Chylothorax happens when lymphatic fluid, that milky fluid full of fats and proteins, leaks into the pleural space.
And that can happen for a bunch of reasons, right? Trauma, surgery complications, even certain cancers that mess with lymphatic flow.
Exactly. It just goes to show you the same problem fluid in the pleural space can have many different causes, and each one needs a specific treatment plan.
Makes sense. Okay, last but not least, let's talk about those collapsed lungs again, pneumothorax. We've touched on it, but there were three main types: spontaneous, traumatic, and tension pneumothorax.
Each one has its own little quirk. Spontaneous pneumothorax, we see that a lot in our younger patients, especially those tall, thin men. It's like those tiny air sacs in their lungs are just a bit more prone to rupturing, letting air leak out.
Right. They could be going about their day, and suddenly, bam! Chest pain, trouble breathing. It can come out of nowhere.
It definitely can. Then you've got traumatic pneumothorax, which usually happens because of a direct injury, a rib fracture, a gunshot wound, anything that punctures the lung.
Okay, so that one's more of a direct hit.
Exactly. And then there's the one that always gets our hearts racing, tension pneumothorax.
The one where time is of the essence. It's not just a collapsed lung. It's a one-way valve. Air gets in, pressure builds up, and it's like a pressure cooker in there.
Exactly. A true medical emergency. We need to know what we're looking for. That respiratory distress, decreased breath sounds on one side, tracheal deviation, and we need to act quickly.
Needle decompression, chest tube insertion, those are lifesavers.
Absolutely.
Wow, we've covered so much ground already. From those common bacterial infections to those sneaky fungal ones. And of course, lung cancer and those really acute situations that can be life or death.
It just goes to show you, pulmonary medicine is never boring. There's always something new to learn and new challenges to face.
Ready to wrap up our respiratory road trip with a look at some conditions that can really put our diagnostic skills to the test.
Absolutely. Let's dive into this last batch of cases. We've got a real mix of respiratory conditions to unpack.
All right, sounds good to me. Let's start with those interstitial lung diseases we've been talking about. Specifically, idiopathic pulmonary fibrosis, or IPF. It's a tough one to grasp and even tougher to treat.
You can say that again. IPF is like watching the slow decline in lung function. Those lungs get scarred and stiff. It's like trying to breathe through a sponge. And the idiopathic part, that's the real head scratcher.
Right. What causes it? We see those cycles of injury and scarring, but what's the initial trigger? It's often a mystery.
Exactly. Research suggests it might be a combination of things: genetics, environmental exposures, maybe even some viral factors. But it's different for every patient.
And sadly, there's no cure. We're focused on slowing down the progression, managing symptoms, and trying to make sure they have the best quality of life possible.
Couldn't agree more. Early diagnosis is so important. The earlier we know what we're dealing with, the sooner we can intervene and hopefully make a real difference.
Absolutely. Now let's go back to pneumoconiosis, those interstitial lung diseases caused by inhaling those tiny particles. We're talking coal dust, silica, asbestos, things that can really do some damage over time.
It's a good reminder that what we can't see can still hurt us. Protecting our patients and ourselves from those workplace hazards is so important.
Couldn't agree more. We need to be advocating for workplace safety measures, making sure everyone knows about potential exposures. We have to be proactive about prevention. Now, for a condition that's thankfully rare but incredibly serious malignant mesothelioma, we've mentioned it a few times, but let's really break it down.
It's a difficult diagnosis to give, a cancer that usually starts in the lining of the lungs, but it can spread to other organs too.
And we know asbestos exposure is the main risk factor here.
Absolutely. Even short exposures to asbestos fibers, sometimes from decades ago, can increase the risk.
And here's a point I think is crucial for our patients. While smoking doesn't directly cause mesothelioma, it can make the prognosis much worse if someone with asbestos exposure develops the disease.
Such an important point. It's never too late to quit smoking. And in this case, it could significantly impact their outcome.
Okay, let's shift gears back to the pleural space conditions that cause fluid buildup or air leaks around the lungs. We talked about pleural effusions, but there are a few specific types I want to clarify. We've got hydrothorax, hemothorax, and chylothorax.
Right. What's filling up that space is important. Each type gives us a clue.
So with hydrothorax, that's our most common type, right?
Exactly. It's basically an excess of watery fluid, often caused by heart failure or kidney disease situations where the body's fluid balance is off.
Like the lungs are drowning a little.
Exactly. And then you've got hemothorax, and that's a whole different ballgame. We're talking blood in the pleural space now.
Definitely a more urgent situation.
For sure. Hemothorax often means we're dealing with an injury, a rib fracture, a penetrating wound, something that's caused bleeding.
Okay. And then there's chylothorax, which always seems a bit trickier.
It's definitely less common. Chylothorax is when lymphatic fluid, that milky fluid that's full of fats and proteins, leaks into the pleural space.
And that could be caused by a number of things, right? Trauma, complications from surgery, even certain cancers that can block lymphatic flow.
Exactly. Same problem, fluid in the pleural space, but so many different causes. We need to consider all the possibilities to make the right diagnosis.
Makes sense. Okay, last but certainly not least, let's go back to those collapsed lungs pneumothorax. We've got our three main types: spontaneous, traumatic, and tension pneumothorax.
Each with its own little personality, right? Spontaneous pneumothorax tends to happen in our younger patients, especially those tall, thin men. It seems like their lungs are a little more prone to those tiny air sacs rupturing.
It's like their lungs are more fragile. They can be perfectly fine 1 minute and then, bam! Yeah. Chest pain, trouble breathing, the whole 9 yards.
It can be pretty scary. Then we've got traumatic pneumothorax, which is a bit more straightforward, usually happens because of a direct injury, a rib fracture, a penetrating wound, anything that punctures the lung and lets that air escape.
So a more direct hit.
Exactly. And then there's the one that always gets our attention, tension pneumothorax.
Oh, yeah. That one's a real showstopper.
It's not just a collapsed lung. That air gets trapped, that pressure builds up, and it's like a ticking time bomb.
We need to be ready to jump in with both feet. Recognize those signs: respiratory distress, those decreased breath sounds, tracheal deviation, and we need to act fast.
Absolutely. Needle decompression, chest tube insertion. These are the tools we need to save lives.
Well said. We covered so much ground today, from common causes to these rare cancers and everything in between. I think the biggest takeaway is that respiratory conditions keep us on our toes.
Definitely. It's a field that's always evolving. We have to keep learning and adapting to provide the best possible care for our patients. And as PAs, we play such a vital role. We're often the first line of defense when it comes to diagnosing and treating these conditions.
I couldn't agree more. Well, that about wraps up our deep dive into the world of respiratory conditions. We hope you found this journey as fascinating as we did. And remember, this is just the tip of the iceberg. There's always more to learn.
So keep those brains engaged, stay curious, and most importantly, everyone take care of your lungs.